Uh, Yesterday, we just started this topic of obstetric hemorrhage, and we just discussed some of the aspects of antepartum hemorrhage. Okay, so we will just continue from there. So, have any one of you dealt with a case with mom with massive obstetric hemorrhage? Yes, anyone, please? So, if you want to share how, what was the problems, if you want to share, Arthur, Dr. Arthur. Why obstetric bleeding is a little more troublesome than any other bleeding? Can anyone answer? You don't hesitate to speak out. Even if you say wrong, no problem. Yes, Dr. Rabia, iPhone, whosoever want to answer. Why I say that obstetric hemorrhage or bleeding during cesarean section is more critical than some other, of course, any other bleeding can be even more troublesome. But what is the peculiarity of bleeding from this uterus? Not yes, this is one aspect, that there are two lives at risk, but are there something else?
There is no collateral circulation.
No collateral circulation. Okay. What about the blood supply of uterus?
Yeah, difficult to control. We need to ligate the major vessels.
Because at term, during pregnancy, the blood supply of uterus massively increase. Okay. So actually there is a lot of blood supply going on and it can bleed a lot. Okay. So this make it a little troublesome. And another thing is that not only because of because usually when there is bleeding, there is some vessel is rupture or something like that. Here one of the reason for if we just say postpartum hemorrhage is actually relaxed uterus. Okay, so this makes things even more difficult, that there are so many factors which are sometimes beyond the surgical control. Okay, if the uterus is not contracting, yes, there may be some medications used, but still it's not like only some surgical skill which can stop the bleeding. So these are few points which make it a little more tricky than it looks like. Okay, so because in our discussion yesterday we were just focusing on antepartum hemorrhage, so we will just continue from there on. So if anyone can tell, what are the causes of postpartum hemorrhage, common causes? Yes, please. This placenta previa, this placenta eta, percreta, increta. Okay, we discussed yesterday. Then uterine atony. What else? Retained placenta. What else? Any other? Of course, the normal coagulation problems. And what else? What do you think? if you will, all people will not speak out, it will be really difficult for me, because I don't want to, I'm not giving a lecture, I'm just discussing with you. Okay. So this is one of the way to memorize this 4 T's: uterine atony, retained product of conception, trauma. Okay.
Vaginal tears, one of the causes.
Yes. So genital tract injury or any coagulopathy. Okay. So another that how will you like assess the bleeding? Like how will you assess that how much bleeding has occurred? This is actually a generalized question. So how will you say that this patient is now need? When will you say that you want to give blood? So usually in normal vaginal delivery, how much blood loss can occur? Up to 500 ml, and in cesarean section up to 1 liter. Okay. So it can occur. And the other, of course, it will be transfusion trigger will not be the same for every patient. So you will be making, this should be in your pre-hand, that you should be knowing about the allowable blood loss, okay, which is calculated with the initial and allowable hematocrit. Okay. So and also with the blood volume. So 3 parameters are being used. According to the weight, you will calculate the blood volume, and then you will see the initial hematocrit, and you will see that maybe, for example, if some patient already have a hemoglobin of, for example, 8 or 9. So this patient actually you will roughly around, if you are expecting around 750, even the average. So this patient, the hemoglobin will fall down and you will need blood. Okay. So these are certain things you should be knowing. And this is one thing. And then you will be looking at the drains. Okay. So another challenge here to assess here, just like in any other surgery, when they are using a lot of wash, a lot of irrigation. So here you have to look at the volume of amniotic fluid. Okay. So amniotic fluid volume, you have to guess actually, because you cannot 100% by a surety by thing. And then another way is that you can use 2 suctions. Okay. The not, of course, not you, the surgeons can use 2 suction. This is for another reason as well. Okay. Because one of the way to control or manipulate the bleeding is cell saver. Okay. If you want to avoid blood transfusion from other patient, you can have used this cell salvage. And for cell salvage, who knows about cell salvage? Who any one of you used cell salvage? We discussed before as that like there is a mechanism which is receiving the blood from the suction, and then there is some mechanism to wash it. Okay. And then it is concentrated in a another you will be washing the RBCs. And remember one thing, that different machines, they can concentrate it to different level, but it is usually around 70% hematocrit. Okay. And then one more thing, that it will not have any coagulation factors or platelets. Okay. So it will be only hemoglobin, like it will be like pack RBCs. Okay. So this is the limitation for that. Why I use this word of 2 suction, because amniotic fluid is one of the relative contraindication for cell salvage, along with fecal matter. Okay. Or malignancy. So usually in these 3 things, you don't use you like it's a fecal matter is absolute contraindication. You will never use it, but usually you can use 2 sections. One is for blood and one is for the amniotic fluid. Okay, otherwise it will be difficult for you, because you will see the drains, then you will see the packs. Okay, and the concept to assess the volume of this packs is that because roughly you can say that fully soaked abdominal gauze maybe 150 to 100 ml, but the exact way is to weigh before surgery and then after being used. Okay, and then there is some formula by which they calculate the volume of blood. So this is how they calculate. And as an anesthetist, you can have a look on the surgical field. You can see directly how much bleeding is occurring, and then of course the drains and the gauze, as I told you, this abdominal sponges and everything. Okay, so like you will be classify according to the like blood loss, and usually class 3, class 4 hemorrhage will need definitely blood. This blood which is lost in like a pregnant patient during cesarean section, this is usually isovolemic. So there is a concept of this 1:1:1, which you might need. Okay, so another way by which you can exactly see like whether you need these 1:1:1 or not is how can you assess? There are different point of care testing mechanism, like you can do INR. Okay, this is one of them. You can there is actually bedside machines by which you can do INR. Okay, but otherwise you can send the CBC and coagulation profile. That will take some time. Other way is to do thromboelastography or rotom. Okay, and when you are looking at thromboelastography and rotom, the waveform is seems a little complex, but the basic theory I will tell you that you have to decide whether you need FFPs, whether you need cryoprecipitate, fibrinogen, and whether you need platelets, or whether you need tranexamic or antifibrinolytic. Okay, so actually the graph looks like, I'm not very good in graph, but one is reaction time, and then this is alpha angle. Okay, so and then this is maximum amplitude. So roughly if the reaction time is more, the patient needs FFPs. Okay, if this alpha angle is less, then the patient needs cryoprecipitate. And if this maximum amplitude is less, the patient needs platelets. Okay, and if the clot is making but it is breaking early, so it means there is hyperfibrinolysis, so you need tranexamic acid. Okay, if the reaction time is increased, patient needs FFPs, which has all the clotting factors. Specifically, if alpha angle is less, okay, it is like more acute, it is not gaining the accurate angle, it means the patient needs cryoprecipitate. And if maximum amplitude is not achieved, this is usually need of platelets. Okay, and if it is making but clotting is breaking, the clot is breaking early, then it is need for tranexamic acid. So usually exact may to because actually other things you will find a lot of things in the books, but this is a specific thing which you should know, and that's why I highlighted these points. Okay, so rest of the manuals which you will be using will be divided into surgical and anesthetic. Okay, and then there are certain radiological ways. Okay, so surgical are usually they do this massage, and then this B-Lynch suture. Okay, and then they may lead to hysterectomy. Okay, and radiologically, actually, they put a balloon in the internal iliac vessels. Okay, surgical also one thing I missed is internal iliac. ligation. This is also surgical. So embolization of the feeding vessel, like internal iliac. Okay, and they can put a balloon, and if it is needed, it is inflated to embolize the vessel so that the blood loss will be decreased. And anesthetic factors will be revolving around if the patient is under general anesthesia, inhalational agents is one of the biggest factor you should be avoiding. Even you can convert into TIVA at that time. You can give some midazolam, you can give some ketamine, because at that time, because it is one of the causes or one of the risk factors for development of awareness. Okay, so if you like when if you are having such case, you should convert into like you should use, either you should avoid it, or because some people still use it because they are afraid of awareness, but at that time priority is not awareness. And you can give some midazolam, you can give some ketamine, you can continue nitrous oxide because nitrous oxide will have no effect. So when you can manage accordingly, and all the other stress factors that you will try to maintain the oxygen, you will try to maintain the CO2, you will try to maintain the temperature, you will try to maintain the filling pressures, and more important is that you will avoid the factor which increase the stress. Okay, so these will be one of the most important factors. So like you will avoid hypoxia, you will avoid hypercarbia, you will avoid hypothermia. Okay, you will give multimodal analgesia, and in the way that because these factors will increase the bleeding. If there is hypothermia, there is platelet dysfunction and patient will bleed more. If there is hypercarbia, patient will bleed more. If there is hypoxia, if the patient is already having bleeding and now oxygen carrying capacity is already decreased, so you have to maintain the FiO2 so that you have to maintain the oxygen carrying capacity. Of course, this will not be a big factor, but still you will try not to have hypoxia. So these will be the things which you should be using. And then last but not the least will be uterine tonics. Okay, so uterine tonics will be either this oxytocin, methergin. There is the sister of oxytocin. It's a newer medication, not available I think in Pakistan. It's available here. Its name is carbitocin. It's coming in with the name of Pabal. Okay, it has longer duration of action, and it has less side effects like tachycardia, and but the mechanism of action is the same. It has less cardiac side effect as compared to oxytocin. Okay, the other is methergin. So methergin can cause, because it's a vasoconstrictor, it can cause hypertension. It is ergot derivative. Okay, then the third will be prostaglandin or PGF2 alpha, carboprost, and this one misoprostol. Okay, misoprostol. This can cause asthma, so like bronchospasm. So, and it should be avoided in asthmatic patient. You have to use with caution in asthmatic patient. There is a lot of debate, a lot of worries and fears and confusion about oxytocin dose. So remember one thing: it is never. If you will ask about from gynecologist's perspective, they will be happy if as much oxytocin you give. But usually it is said that you should not give more than 5 international units as a bolus. Okay, and you should not give more than 10 international units per hour infusion. So it is like that. And what they usually ask you to do, that put 40 units into. Okay, so 40 units Cinto, they asked to put it in 500 ml, and then you have to give it at 125 ml per hour. So it will be around 10 units per hour. So, but remember one thing practically, this is more of the practical thing, that you, for example, if you put this number of units and now you want to give faster fluid administration, So you can reduce the dose. Like for example, if you put instead of 40, you put 20 units, okay? And then you can make the rate up to 250 ml per minute, okay? Sorry, 250 ml per hour. So you can, similarly, if you put 10, you can give it even up to 500 ml per hour. I hope you understand, okay? So the the administration of syntocinon is important rather than how much fluid you are giving. Because sometimes if you tell them we have put it, so because they don't understand this thing. So I hope you understand that if you are putting in 40 units in 500 ml, you will give it at 125 ml per hour. If you, and similarly, if you put 20 units, you can go up to 250. And if you are putting 10 units, you can go up to 500 ml. It is especially in that scenario in which patient you don't have too much IV lines, and you don't want to waste IV line only for giving of oxytocin. So then you can reduce the number of units you put in the fluid, and you can increase the rate. Okay, so this is some of the thing. If you give increase, there are like cardiac this is just like ADH. So patient will have volume overload, tachycardia, okay, and unpleasant sensation. Okay, so these signs of overload and tachycardia. So this is just basic concept of because usually when it suddenly patient bleed, it's an emergency. So you have to, another important thing which you should be knowing is what is massive transfusion protocol. Okay, so this is an important thing. It is the same concept is being used for all other hemorrhages, any other hemorrhage, anywhere, any trauma and everything. And it is it's a protocol based thing, hospital based protocol, and they have O negative or O positive, usually O positive, but it may be O negative or O positive, because O negative is not a very common blood group. So O positive or O negative blood group, and they have made a set of PRBCs, FFPs, okay, cryoprecipitates. This may be altered, and platelets, okay. It's also called as shock pack. So when you will call, as there will be a specific number. Of course, in the hospitals where this system is being applicable, but they can ask this question in your exam, that what is massive transfusion protocol. So it is a protocol, and this will be uncross matched. Okay, this will be uncross matched blood, and they give it, and the number of PRBCs may vary, but usually it may be 4 or 6 FFPs, platelets, precipitate, 4 units. Okay, and this is one thing, and another thing is that, again, as I told you before, that this 1:1:1 hemostatic blood transfusion, it is if you don't have the facility of TAG. Okay, if you have the facility of TAG, you should do TAG, and then accordingly the units of blood, the blood products which are needed, you will give. Because there is no concept of blood transfusion. Okay, there is no concept of blood transfusion. You are giving blood products. So these are all blood products we are giving: PRBCs, FFPs, cryoprecipitates. So this is just the basic concept. Any questions up till now, please? Anyone wants to ask any question? Okay, so then only one thing, because I told some basic this is common thing which is there in any, because your purpose of resuscitation is to avoid the patient going in lethal triad. Okay, lethal triad is acidosis, hypothermia, coagulopathy. Okay, because this is a lethal combination, and it will be leading to the patient can go in DIC, patient can go in multi-organ failure. Okay, and then you have to deal with the complications of massive blood transfusion. There are so many definitions of massive blood transfusion. There is no like one word definition of massive blood transfusion. If you are giving even half unit of volume, like equivalent to the half blood volume in a very fast, this will be considered as massive blood transfusion. Even if you are giving very like 1 to 2 units you are giving every hour for few hours, even this will be considered as massive blood transfusion. So in addition to the minor reactions, you can have overload. Okay, you can have trolley, acute lung injury, transfusion related there are another some word transfusion associated cardiac. What is TACO? Can anyone tell me what is TACO? I remember, I forgot what is TACO. Okay, like I cannot recall because there will be cardiac overload, there will be pulmonary complications, and then the electrolytes. Electrolytes, you can say the homeostatic conditions. Like there will be the problem, patient may have hyperkalemia, patient may have hypocalcemia. Okay, and then initially there may be acidosis, but later on alkalosis, metabolic alkalosis. When this citrate is being metabolized, it can result in alkalosis. Okay, so that's how you will be looking at. So I just give you the basic concept of bleeding and how to manage. Yes, one more question which they ask is that how will you prepare a patient placenta previa? What teams? Because this question is being asked in different, even in interviews, even in oral examinations, and even in the talks that you have a patient which is known case of placenta, for example, like Rita. So how will you prepare it? Which subspecialties would you like to consult before? So you will be consulting, because anesthesia and ICU are separate in majority part of the world. In UK, Ireland, it's the same, but you will say that you will be arranging the bed in ICU. You will have a contact with blood bank. Okay. You will be consulting the OR coordinator, or you can say, or OR staff for the logistics. Okay. Because this patient might need massive transfusion, and so blood bank and pathologist. Okay. To arrange the things, you should have rapid infuser system. Okay, you should have blood warming devices. Okay, if it is possible to have cell saver. Okay, you should have trained anesthetist, trained staff. Okay. In addition to that, you should be consulting the interventional radiologist. This will be a team management, an interventional radiologist, surgeon, urologist. Because sometimes if it is per Krita, it can even go up to the ureters. And if you have a complicated surgery, every likelihood there will be a risk that while closing, they can damage the ureters. Okay. So this one, and then urologist, general surgeon. Okay. So I think this is related to, we will just have a look. And whenever you are giving blood, you have to assess the need of how much the patient needs, how good patient is responding. Okay. And there are certain questions they will be asking them how, because this case will be in different scenarios. Maybe you have a patient who unanticipated bleed. Okay. There will be a patient who in whom you are anticipating that there will be bleeding. Okay. And like uh, there may be a patient who is hemodynamically stable at to start with, and there is a patient who is not hemodynamically stable. As I discussed yesterday, that maybe you have a patient in which you started on regional anesthesia and suddenly patient bleed. So right, like things you can have a different challenges. If you have a patient with like patient is not stable, then you can, as here written, ketamine you can use. Otherwise, the normal, if patient is stable to start with, patient even placenta previa patient, if you are giving general anesthesia, people may be saying that you are giving ketamine. No need for ketamine. If the patient is initially till the time they don't open, patient is normal. So you can start in normal routine rapid sequence induction or modified rapid sequence induction according to the availability. And of course, you will be looking for intra-arterial blood pressure monitoring. You will be looking for CVP, if possible, this cardiac output monitors. Okay, because it will help you a lot. Of course, you will have urine output, you will have temperature monitoring, and if you have a complicated patient with some other comorbidity, you will be handling it separately. In all, when you are telling all this stuff, you are bound to miss that this patient is pregnant. So you never miss to say that there are altered physiological, pharmacological, and anatomical considerations which are there in any pregnant patient. And similarly, when I use these words, people think that I'm only telling about VIVA. But remember, even in MCQs, they will not tell that you have to look at automatically when you have a pregnant patient, you should be thinking that this patient have two lives, and you have to consider these things. Okay. So this is what we have actually, number of things, surgical maneuvers. One thing which I did not see in Pakistan, here it's commonly used is Bakri tamponade balloon. Okay, it's placed through the per vaginally, and they inflate it, and this is one of the way to control the bleeding. Okay, so this is, I never used in Pakistan. I saw it here commonly being used. And peripartum hysterectomy, of course, whenever they are doing hysterectomy, you have to make sure the consent has been taken. And if you have an elective patient, even being an anesthetist, you have to make sure that the consent for hysterectomy is being taken pre-operatively. Okay, because this patient might need it, might end up in having hysterectomy. So these are the things. As I think a number of things I have already told you, the CC, vicious cycle of hypothermia, acidosis, coagulopathy, and electrolyte imbalance later on you will be looking at. So please, if you have any question, yes, I'm sorry, I forgot this no factor, no. I don't know why I forget. Even I was having an interview for the Saudi Commission consultant. I did not mention this thing. And today even I have forgotten. So Novo 7, this is factor 7A. Yesterday, I answered one of the question that factor 7A is why it is important, because the new cell-based theory of coagulation is based on initiation, amplification, and propagation. So it is one of the most important coagulation factor, which is responsible for the activation of coagulation cascade. So when nothing is being worked, they are using factor Novo 7. I have never used it in my life, so I don't have experience about it. It's available here very commonly, but it's my luck that I don't need to use it. Okay, so I think that's it. So any questions? Unfortunately, today very few people came and none of you are asking any question. So I hope I have explained to you this topic, and even later on, if you want to ask any question, you all are welcome. Okay, so I will finish here. Tomorrow, we will do the next topic, most probably this one, or anticoagulants, or I may continue with some of other topic related to pregnancy, which is there. And because these days I'm doing this, I'm just trying to have a concept of this book, Clinical Anesthesia Viva book. Okay, so we are doing it. We have done a number. Yes, yes, Dr. Naveed. Yes, please. You raise the hand. You want to ask any question? Any question, Dr. Naveed? Okay. So anyways, thanks a lot. So tomorrow, same time, inshallah. Assalamu alaikum.